All of this that I'm showing you now is available for research scope to every one of the centers contributing to WAPPS. And I will tell you how you can get access to this data. And the way the research network works in WAPPS is that for all those contributing to the database, for all the active center, you can request access to your data for sure, and also to broader set of data, going to the entire data set for specific research question. This is now the base for PubPK individual profiling, no matter if you do it with WAPPS or with other systems. Good morning or good afternoon, everyone, wherever you are. So thank you for staying with us till the end of this series, or for joining today if your interest is mostly learning what we have done and what we can do with the data that are collected through WAPPS-Hemo. It will be a different webinar. It might not be something that every one of you does personally, but for sure is something that every one of you contributes to by simply using WAPPS. And let's start there indeed. If you scroll down on the homepage of WAPPS, as I'm doing, you get to a page where you see the world map with the countries where WAPPS is active and some data, some measures of the data we are collecting. I believe you all know, but I'm reminding you that if you go over any country, you will see in brackets how many centers are active. So there are 27 in Canada, there are 112 in US, there are only one in Iceland, there are 6 in Finland, and so on. And you see a number. That number is the number of PK profile in that country per million citizens. So if you look at Canada first, in Canada we have 44 PK profile per million people. In US, there are 8 per million people. In Iceland, where they essentially profile the entire population, there are 271 per million people. In Finland, 125. So this is a sort of a measure of the uptake of population PK profiling country by country. All these data that are collected around the world are summarized somehow in this table on the left. 745 centers active on WAPPS, 13,000 individual patients, 27,000 PK studies, of which some were combination. For example, you do 2 studies, you merge them into one profile. The number of unique profiles are 20,000, which means that 1 in 2 patients has at least 2 profiles, likely because they switch concentrate. So they have a profile on one and a profile on another. And then you see numbers for children, 6 to 11, 3,000, 0 to 5, 2,000. These are large numbers, and these numbers are those that allows WAPPS to be a powerful research tool. Another view is data by concentrate. You know, if you look at factor 8, there are about 5,000, little shy of 5,000 profiles on eloctate, 4,500 on advate, and so on. You can go down and see for each of the concentrate, how many profiles do we have. For hemophilia B, for example, 1,200 on alprolix, and the second most profile, these Benefics with 700, and so on. The other thing you know, and then I'll move to the database, is that on the PK report you get through WAPPS, you essentially get very minimal set of information. You get the half-life, and you get the time to concentration. You get an interactive time to concentration time profile, what the concentration is over time, the typical profile we can get for every patient. We believe that that's what you need for tailoring treatment to the individual. And so to keep the PK report simple, that's the information we provide. However, in the back end, the population PK approach requires to calculate all of the PK of a patient. So here you see the clearance, the volume, and so on. Where does all this information sit? Now, let me stop for a second sharing this screen, and let me try if I can do this way. Can you now see a folder? Yes, I believe you do. Now, you may not be able to read because this is small size, and I don't think I can change it on my Mac. But this is the folder where every week data from WAPPS are dumped. And there is documentation, what the process is, which variable we collect, how they are calculated, and so on. All of this that I'm showing you now is available for research scope to every one of the centers contributing to WAPPS. And I will tell you how you can get access to this data. So there is a documentation component, and then there are two main databases. The production database. The production database is summarizing the data as they are behind the website. So essentially is all the PKs that are requested, produced, delivered, all the treatment plans that are generated and used, and so on. Is an unabridged version of the database, is the one that allows the system to show you data. And we use that mostly for counts, how many centers, how many patients, how many profiles, and so on. For research, we have a second database, and we call it research database, where we sort of refine data by eliminating, for example, or classifying PKs taken around surgery, PK taken in patient with inhibitors, duplicate PKs. You also know, or you may imagine, that over time we had improved our models. But once we release a new model, say we have now a better model for ADVET, I think we are at version 5 or 6, because while we collect data, we redo the modeling, we have more powerful models. We don't go back remodeling the data that were generated in the past, because those data were released to patients, were used to create treatment. They need to stay there, even if they are not perfect, because they were the base for their treatment. But had that patient being profiled today with the same information, we would use a more powerful model, we would get likely more precise data. So in the research database, what we have is all the data for each of the patient calculated using the most up-to-date model. So if you are looking at the database, for example, to, I don't know, compare to concentrate, or build an algorithm to switch from one concentrate to another, you want the best data available at that moment. And you want them modeled with the most accurate model available at that very moment. So the research database is continuously recalculated and updated to allow research with the best, most precise data. Both for research and production, we have an archive, and then we have a series of files. These are simple Excel files. In the archive, we have folders for each week of the year. And then we have an older archive with previous data. Essentially, what happens is that every week, the data are extracted from the database automatically and are delivered into this set of Excel files. I'll show you a couple of them to you in a second. And everything that was delivered the week before becomes archived. And this is because the WAPPS database is a live database, so it changes continuously. And if you were to interested in doing research on the uptake of some concentrate or the uptake of population PK profiling, for example, in a country, you would not be able to do it directly on the database. If you wanted to know how many patients were there in January, February, March, April of 2022, you could not do it directly on the database, but you could do it by using all the data that are stored in folders. So we have built this system early on in the WAPPS life, thinking of the most common research question that one may want to ask. Now, I'm showing you, for example, the PK profile data set. Let's see if I can make it bigger enough for you to see. Are you seeing now an Excel sheet? Okay, so let me make it bigger. Each of the file has a first tab where you essentially have all the variables with their definition, what the unit of measure is, what the field is, and what that variable describes. And you see there are several here. And if you move then to the actual file has one row per PK profile in this case. And for each of them, there are information about the ID and the WAPPS-Hemo identifier. These data are anonymized, so you can't go back to the patient, even if you receive this file for research. But in-house, we can link through these numbers to the database. The center is there. So you see, for example, a PK from our own center, from the Children's Hospital in Philadelphia, Padua in Italy, and so on. So the center is identified. Depending if it's needed or not, this column can be taken out when data are provided for research. The country is there. So if you were interested in country level data, we would take away the center, but still leave the country. And then you have the information on the patient, the age, age in year, age in months, weight, height, and so on. If I go to the PK component, let me get there. Okay, here you have the maximum concentration, the AUC, the clearance, volume of distribution at steady state, and so on, down to all the half-life with confidence interval and the POP-PK parameters. So, for example, if one was interested in comparing WAPPS models with others, it would need this eta here to do their job. Now, this is one of the table. This is the one about PK profiles. We have one about the PK infusion data, where you would have for each of the infusion that were provided, the time and the measurement. And those might be used, for example, to remodel. And we had cases where the data that were used out of WAPPS were actually those needed to remodel. I'll show you another file. I'll go get it in the production, is the treatment plans. So the treatment plans is a file that reports all the information on those patients for whom a treatment plan was produced. And for example, for those patients, you would see the drug name, you would see the dose that is administered, what is the trough and the peak achieved, and for example, this patient treated every 3 days, every 3.5, 2 days, and so on. Again, plenty of information if someone wanted to explore how one or another concentrate is normally used. And of course, these are source data that can be elaborated. I stop for a second. The main message here is that all these data are available and ready for analysis. And the way the research network works in WAPPS is that for all those contributing to the database, for all the active center, you can request access to your data for sure, and also to broader set of data, going to the entire data set for specific research question. If those are generic research questions that apply to all concentrates, we only need to, be confident in the research design. If they involve one single concentrate, usually we ask the center who are contributing data to the data set that would be used for the analysis to tell us if they are happy or not to contribute their data to the project. So sometimes you ask for the data, we just provide them. Sometimes you come with a question and we help you investigate the data to answer the question. Some other time, if your question is about a specific concentrate, we'll say, okay, great idea. Let's check which of these 750 center contributed data to this specific concentrate, data that would be useful and used in this study, and we ask them if they are willing to participate. The other general rule is that anytime that is possible, all those who contributed data are acknowledged in an appendix in the publication. Okay, now let me move back to the browser. Can you see the browser again?
Yep.
Okay, so I'm going now to PubMed to show you some of the research that was done out of WAPPS. And I don't expect these to be all. There are 34 studies where I'm a co-author. So it was easy for me to find this study by searching for, my last name and WAPPS. There are others that use WAPPS data and have no co-authors in Hamilton, and those may not be on this list. So there are 34, and if you look at the spread over time between 2016, when we published the first set of study, to this year, more or less, there were 4 or 5 studies per year published out of WAPPS. Which to me means is a valid data set, is a valid source of research information. And hopefully continue helping us to know better around hemophilia treatment. If we go to the oldest, initially there were studies mostly around what is the value of PK in treating hemophilia patient, and I believe that as of today that idea doesn't need to be rehearsed anymore. We all know how it can be used, but back at the beginning we had to make the case that this was important, and then we published 2 papers, and I like to mention them because they still give a lot of information around what the WAPP is and what it does. So the study protocol that we use to develop the infrastructure and the data analysis protocol to build a generic model were published early on in 2016 to provide evidence to what WAPPS was actually doing. If you are interested in how does the system work, more recently, and I believe is in the first page of this set, no, it's actually in the second page, sorry for that, is this paper here, Development and Evaluation of the Population Models for the WAPPS-Hemo project. This paper that we published in 2020 in hemophilia, mostly was the group in Waterloo, reports for each of the model we have, for each of the concentrate, the performance measures and the optimal sampling time. So if you wonder, can I use 24? Can I use 24 and 48? Can I use, peak and trough only? For any specific concentrate, there is no general question. We have covered these in our first webinar. If you are interested in peak, you better sample around peak. If you are interested in trough, you better sample around the tail. But in general, there are ideal points for each concentrate. And those are reported in this publication that also tells you the precision of WAPPS for each of the concentrate. Then there are a few papers that are mostly educational. Stacy Croteau in Boston did a lot of work by investigating usage of WAPPS and particularly usage to tailor treatment. So medical decision-making outcomes, this paper goes into the nitty-gritty of using and what you see. This paper here, patterns of blood sampling and patient characteristics among clinician user. We have gone back to the database, looking at the PK infusion data set and checking what is that is done most often and which kind of sample are more commonly used. And we have reported a sort of a summary. Again, Stacy was leading this task force on usage. And if there's any similar question that may be relevant to any specific setting, you are more than welcome to propose the research and either get the data and do it or propose a collaborative study. Other educational papers, for example, are in this series here. Again, Stacy Croteau summarizing how to embed PK profiling in routine hemophilia care, again, based on data collected through WAPPS. You know for sure that out of the WAPPS experience, there were also guidelines released by ISTH. This paper here on research and practice in thrombosis and hemostasis, or this paper by Maggie Ragni on switching to extended half-life. Again, the paper built a lot on evidence that was provided through the WAPPS database. And there are many more educational that are more in general, telling the lesson learned by using WAPPS. Then there are papers that we use to communicate what we actually learned technically. For example, something we didn't know, at the beginning, was how relevant the baseline measure was in estimating, and how much the precise or less precise measure of the baseline influence the capacity of the system to predict the PK. And we started realizing that while doing, because we saw that depending on the lab capacity of different centers, the estimates were slightly different, and actually not that slightly different. And so out of those observations, this paper was published in 2018, and this is now the base for PopPK individual profiling, no matter if you do it with WAPPS or with other systems. And this is one, for example. Another one is learning the importance of body weight. And this is something that we actually decided to add to the WAPPS report. If you look at the WAPPS report, you will see that for each patient, we calculate the free fat mass, the lean body weight. Why is that? Because that's really what you would need to dose for if you want to obtain a specific peak. We all think that giving 50 units per kg, we get 100% factor 8 or 100% factor 9. Well, that's not really true. You get 100% if you dose 50 units per kg of lean body weight. But if your lean body weight is 50 and your real body weight is 65, which is, a standard amount of fat in Caucasians, if you dose 50 by 65, you actually get to 120 something. If you want to get to 100, you would need to dose 50 by 50 kilos. And this explains, for example, why obese patients bleed less, which is counterintuitive. You would imagine their joint have a bigger effort to do while walking the heavy individuals. But we overdose them because we dose them on their total body weight, not on their lean body weight. And so they get to very high level of factor. Now, this is not just curiosity, because this is very important if you try to calculate equivalence of different regimens for patients with different weight. You could actually save a lot of money if you were weighting by lean body weight, obtaining the same level in the blood. This was not was hypothesized before WAPPS, but was proven when we were able to model the thousands of data points available in WAPPS. Other similar finding were the proof of how much blood group matters, and the importance of knowing blood group in treating hemophilia A. Blood group type O is associated with shorter half-life. And again, there's another paper, I'm trying to save time in this series that is about blood group. And then there are papers that were showing clinical evidence. For example, the first one appeared, the first author was Manuel Carqueo at Sick Kids, when we switched in Canada between Eloctate and Adinovate in children, using WAPPS to do the profile before and after per routine clinical practice, allowed Manuel Carqueo to go back to the database, extract the data for all the patients they switched, and show that on average, the two products are absolutely identical, but individuals, they may do equally good, or they may do better on one or better on the other. And there's about a 15% of patients that may be doing better on one or the other concentrate. And this was shown later on more in general by the Dutch group. Let me see if I can find the paper. I think it's in the previous page, by Olav Verslot, and across the entire database of WAPPS, we found that about 10-15% of patients, when switching to long-acting, this paper here by Olaf Verslot, have actually no gain in their PK profile. And similar data were shown, for example, in Finland, by this group led by Rita Lassila, where they observed the switching to extended half-life in their own population, again, requesting all the PK they have done in their patient before and after the switch, and then comparing the clinical outcome. Similarly, a similar study was done in Germany, for example. Some of these studies, and then I think I'll move on, show new model. So, for example, we did not have a model for Eloctate in pediatrics, and this French group, using PK data out of WAPPS, extended the model for Eloctate to pediatric patients. We didn't have access to dense data on Adinovate. We were, struggling getting a research agreement with a manufacturer to get data. And while for most model, we have developed the model using data from research trial, dense data, 7 or so data point after an infusion, for Adynovate, we started a new way of building model directly from sparse data. And actually, the model was exceptionally well performing, and the paper was published on Clinical Pharmacokinetics, was the best journal in the field. A similar approach was then used for Fundy and alphanate. Fundy and alphanate, different case, collaboration was fully open with the company since the beginning, but they didn't have dense data in formal PK study. And so mostly with colleagues in France in Spain and Brazil, we collected 100 or so full dense data PK through WAPPS, and we use those to create a model. And the model is now used for other patients. Lastly, all the research on switching. We have explored last time how the switching tool works. The switching tool is supported by 3 papers, again, produced out of the database. Mostly is the research of Jackie Yu and Andrea Edgington in Waterloo. There are also additional papers that don't appear in this list. For example, you may know of Jeff Stonebreaker, the chair of Data and Demographic Committee of WFH paper, where he presents a coefficient to transform extended half-life usage or even Hemlibra usage into units of factor 8. And the goal is to show the variation in units per capita that WFH calculates for all countries in the world. And it gets complicated to calculate unit per capita when patients switch from standard to extended to Hemlibra if you don't adjust the real units to the theoretical units of factor 8 that would be used instead. So Jeff did that math independently, based mostly on usage reports, but then he wanted to have a second way of calculating the same coefficient to see if those were reliable. And he did that confirmation calculation out of the WAPPS database. So he requested the data, and then he compared on the treatment plan table what the usage on average was in the WAPPS database for patients switching from one to the other. And again, those numbers came out the same as he had in his own approach. There was a study validating Benefix use once a week in France, done without our participation, but using all their WAPPS data. They requested all the French data, all the French PK on Benefix use. Actually, they did something even more. This is another kind of research that can be done. They had their own infusion log, and they wanted to use the WAPPS model to model their data and see what the time under or above given concentration was, which is another kind of research that's possible and does not require you to input every single information in WAPPS. If you have a research data set and you want to elaborate it using the WAPPS model, you can contact us, connect. We can elaborate your data set, give you back a data set with the additional model information you may need to, may want to have. There are ongoing studies in Italy trying to correlate genetics and PK, in Finland, Greece, France, Germany, that we are not part of. WAPPS is only providing the data. Now, how do you have access to this data? Essentially, there's no system on the website. I mean, you can use the contact us, but essentially, these are not things that happen every day. So when you either explore a research idea or you have a research idea and you want to see how to get the data, you just contact the core team at WAPPS. And essentially, we may need to have an MOU, a non-disclosure agreement, for the data being used only for the scope that you are declaring, but that's really a simple procedure. In the term of use, the one that everyone agrees to when becoming a WAPPS user, it says that data in the database will be used for research, provided the research is ethically approved, and that everyone can use data. The only requirement is to let the core group at WAPPS know that you are using data. Even if you are using your own data, we'd like to know about what is published. We like to keep a list of the paper, and we also want to make sure that references to WAPPS are appropriate. There were initial reports saying WAPPS does not calculate the AUC. It's not true. The AUC is not in the report, but is in the backend. And if those authors had just contacted us, we would have told them the AUC is there. If you want it, you can have it. But just, assuming if it's not there, it's not calculated, was avoidable by a minimal interaction. We have never denied data to anyone. We just like to be supportive and collaborative.